Hello, lovely people. It's Medicosis Perfectionatus, where medicine makes perfect sense. Welcome back to my cardiology playlist. Expect a lot of cardiology videos in the next few months. Coarctation of the aorta. Here is your aorta. We start as ascending aorta, then aortic arch, and then the descending thoracic aorta. And then once it pierces the diaphragm, it becometh abdominal aorta. Coarctation is this narrowing of the aortic arch, as you see. You see this? Narrowing. It was normal, but then it got narrow. That's the coarctation. When you think of aortic coarctation, just remember two. Everything here is two. Types. We have two types. There is congenital aortic coarctation and there is acquired aortic coarctation. We can also classify it into pre-ductal aortic coarctation if it happens before the ductus arteriosus, or post-ductal aortic coarctation if it happens after or distal to the ductus arteriosus. As for physical exam findings, we have two main things: pressure and pulse. The pressure is subdivided into two phenomena: hypertension in the upper extremities and hypotension in the lower extremities. As for the pulse, we have brachio-femoral delay. The brachial pulse upstairs happens before the femoral pulse downstairs. Moreover, the brachial pulse has a higher, bigger volume than the femoral pulse. As for management, we have two options: medical and surgical. Severity, we have two types: mild versus severe. Now smash that like button and let's get started. This video is part of my cardiology playlist, which is epic. Don't forget to subscribe. If you remember my discussion on the cardiovascular physiology, we talked about the adult circulation. Here is oxygen in your lungs. You breathe the oxygen in, and then the oxygen is going to go to the pulmonary veins. The pulmonary veins will bring this oxygenated blood to the left atrium. Then this oxygenated blood will flow from the left atrium to the left ventricle through the mitral valve, which is the only heart valve that has two cusps only instead of three. After this, the oxygenated blood will leave the left ventricle and will go to the aorta through the aortic valve. Once in the aorta, we can go all over the body. We can supply oxygenated blood to the organs upstairs and the organ downstairs, upper extremities, lower extremities. The oxygen will reach my target cell. The cell will take the oxygen and dump out the carbon dioxide. Take the nutrients, throw away the waste. The carbon dioxide and the waste are going to the veins. The veins will go to the inferior vena cava downstairs and superior vena cava upstairs. Together they bring the deoxygenated blood to the right atrium, then to the right ventricle through the tricuspid valve. Next, this deoxygenated blood will leave the right ventricle and will go to the pulmonary artery. Pulmonary trunk first, then right and left pulmonary arteries, and then we give this deoxygenated blood to the lungs in exchange for oxygen, and this is called gas exchange. And then the oxygenated blood will go back to the left atrium and you continue the cycle. But this was not the case in the fetal circulation. When you were a fetus, your lungs were black holes, empty dark spaces with very high resistance. Because of that high resistance, no blood could dare to flow there. Let's review some physiology and biophysics. Remember that flow equals the pressure difference divided by resistance, and resistance is inversely related to radius. If I told you that a fetus has lungs with very high resistance because they are stiff and condensed, so think of them as constricted, so the bronchi are not open. Nothing is open yet. And what's going to happen to the resistance as the radius decreases? Radius decreases, resistance increases. And when resistance increases, what's going to happen to the flow of the blood to the lungs? It decreases, which means any blood in the pulmonary trunk cannot reach the lung because the lung has very high resistance, which means no flow will happen. Therefore, this blood in the pulmonary artery has to go somewhere else other than the lungs. And that's why we have a ductus arteriosus between the pulmonary artery and the aorta. What would you call the duct that connects two arteries together? Ductus arteriosus. But what did we call the duct that connected two veins together? Ductus venosus. During embryological development, the blood is flowing from the pulmonary artery to the aorta because the pressure in the pulmonary artery is higher than the aorta. Why is the pressure in the pulmonary artery higher than the aorta? Because resistance is high in the pulmonary system or in the lungs. Remember that my pressure equaled cardiac output times total peripheral resistance. So if resistance of the pulmonary system is high, the pressure in the pulmonary artery will be high, higher than the aorta, and that's why blood flows from the pulmonary artery to the aorta during fetal development. Now take a deep breath, literally, because you've just been born. You will breathe for the first time ever, and your lungs will open suddenly. Oh, they will dilate. Radius goes up, resistance goes down. When resistance goes down, flow of blood goes up, which means the blood is leaving the pulmonary artery and going to the lungs, which means we usually do not need this patent ductus arteriosus any longer because the pressure in the pulmonary artery will actually decrease and the oxygen will help us close this patent ductus arteriosus and change it into ligamentum arteriosum. To learn more about this topic, I have a dedicated video titled Fetal Circulation. Think of your heart as a factory. There is input coming to the factory from the venous side, and there is output leaving the factory in the arterial side, and this will distribute that blood all over the body. That's the role of the aorta. Input is called venous return. Output is called cardiac output, and the cardiac output depends on what? It depends on how fast the heart is beating, time how strong each beat is. Cardiac output is the volume of blood ejected by the heart per minute, which depends on how fast times how strong. Heart rate times stroke volume. Suppose that with each beat I pump out 50 mL of blood per beat, but I beat 100 times per minute. Multiply them together, you get 5,000 mLs per minute. That's your cardiac output, about 5 liters or 5,000 milliliters per minute. Is this the number for the left ventricle or for the right ventricle? It's the exact same number for either ventricle because all of that blood in your body will have to go somewhere. All of the blood that's in the left ventricle eventually will reach the right ventricle and vice versa. Otherwise, you'll explode. Cardiac output is heart rate times stroke volume. Let's draw this together right here. That's the cardiac output. Multiply this by the resistance and you get the blood pressure. When resistance goes up, pressure goes up. When resistance goes down, pressure goes down. When cardiac output goes up, pressure goes up. When cardiac output goes down, pressure goes down. As long as the other variable remains the same, of course. More important equation. So we just said that the cardiac output is heart rate times stroke volume. This is important. Then blood pressure will equal the cardiac output multiplied by the total peripheral resistance, or simply resistance, which is uppercase R. Resistance is inversely related to radius, or radius to the fourth power. And then there are two equations for flow. You can define flow as the change in pressure over the resistance. P1 minus P2 over resistance. There is another equation for flow, which is the volume of blood per time. It's the volume per time. That's my flow. I want you to look at this equation carefully. Let's do some crisscross action. You will have the delta P equals the flow times the resistance. This delta P is what? This delta P is pressure. So let's just put it as P. How about the flow? Well, the flow could be considered the cardiac output. And what's the resistance? That's the total peripheral resistance. Look at this equation and this equation. Oh! So the equation of blood pressure equals cardiac output times TPR is the exact same thing as this equation, which is flow equals delta P over R. It's just crisscross. I bet you did not know this, did you? See, medicine makes so much sense once you understand what the flip you're talking about. Now bring a piece of paper and draw with medicosis. Let's go. Here is your left ventricle. Here is your lovely aorta. Boom. And there you go. The aortic arch has 3 big branches that you can never afford to forget. You should be able to wake up from a coma and still not forget the 3 branches that come out of the aortic arch. Number 1, the brachiocephalic artery. Number 2, left common carotid artery. Number 3, left subclavian artery. This brachiocephalic artery has a beautiful name. It's called brachio. Brachium is your arm. Cephalic. Cephalo is my brain. Because it will divide into subclavian artery and right common carotid artery. As for the left common carotid artery, it's here. It's a direct branch of the aortic arch. And the left subclavian is also a direct branch of the aortic arch. There is no brachiocephalic artery on the left side. But where are the coronary arteries then? The right coronary and the left coronary come out of the ascending aorta, not the aortic arch. Let's review. What's this? This is a coronary artery coming from the ascending aorta. Then the three branches of the aortic arch: brachiocephalic, left common carotid, left subclavian artery. Please never ever forget these branches, because some years later I might suffer from a car accident and be your patient. If I ask you about the three branches of the aortic arch and you forgot, I'm out. Brachiocephalic artery, left common carotid artery, left subclavian artery. Now, where is the coarctation of the aorta? It's almost always distal to the origin of the left subclavian. So not here, but distal to it, you will start your wonderful coarctation just like this. So the coarctation is almost always distal to the origin of the left subclavian. More anatomy. Here's my brachiocephalic artery, which will divide into right subclavian and right common carotid. The right subclavian artery will later become the right axillary artery in your smelly axilla. Then the right brachial artery. Then it will divide into radial and ulnar arteries on the right side. As for the right common carotid artery, it will divide into external carotid artery for your face and internal carotid artery for your brain. You see this wonderful subclavian artery right here? Yeah, it will give us a lovely branch known as the internal thoracic artery, aka the internal mammary artery. Why thoracic? Because it's in the thorax. Why mammary? Because it's near the breast. Don't forget to like and share. If you really want to understand aortic coarctation, bring a piece of paper and draw with medicosis. Here's your right atrium, and then here's your right ventricle. Here is the left atrium and therefore the left ventricle, and there is my interventricular septum. Then this left ventricle will give us the beautiful aorta just like that. And we have ascending aorta, we have aortic arch, we have descending aorta. Now what are the three branches of the aortic arch, please? Let's go. Brachiocephalic artery, left common carotid, left subclavian artery. Then there is your pulmonary trunk, right pulmonary artery, left pulmonary artery. This is not Pennsylvania. Instead, this will communicate with your aortic arch, and this is called the ductus arteriosus. During embryological development, blood flows from the right side to the left side because the pressure here is greater than the pressure there. So the flow goes this way. Now, what happened after I'm born and take the first breath? This ductus arteriosus will close and become ligamentum and arteriosum. Now let's draw the coarctation of the aorta. Let me draw it here. So this aorta is narrow like this. We have thickening of the tunica media of the aorta. Some hypothesize that this is due to lack of growth or lack of development or defective development in the aortic arch and its branches during embryological development. Now I want you to look at this coarctation. This coarctation began distal to the left subclavian artery. And in this illustration, the coarctation of the aorta started before the ductus arteriosus. So this will be pre-ductal and not post-ductal coarctation of the aorta. So what are the consequences of having coarctation of the aorta? Number one, you have outflow obstruction. Yes, because I cannot get that blood to go from this beautiful arch to the rest of the aorta. Now let's think what's going to happen to this obstructed end. Okay, what happened to the radius here, please? The radius went down. And since resistance is inversely related to the radius, resistance goes up. And since flow is inversely related to resistance, so therefore flow will go down. The amount of blood flowing here, the volume of blood in the aorta going in this area will decrease. So what's going to happen to the volume of blood reaching your lower extremities or the lower part of your body? The answer is it will decrease and decrease blood pressure in the lower half of the body, such as the lower extremities. As a result, you are getting less of that beautiful oxygenated blood to your legs. So your legs will turn blue and you can get intermittent claudications of the lower extremities. This is what happened distal to the obstruction. But how about proximal to the obstruction? Well, let's talk about it. How is my radius? Your radius is large. Unlike here. How is my flow? My flow is big. Unlike this. Don't forget physics. Pressure equals force over area. What's going to happen to the force here? Well, since I have tons of flow, I have tons of volume of blood here because it cannot leave. I have tons of blood. The force goes up, and when the force goes up, pressure goes up. So the pressure going to the brachiocephalic artery, and therefore the right subclavian, and right common carotid will go up. The pressure going to my left common carotid will go up, and the pressure going to my left subclavian will go up, which means the pressure in the upper part of the body will go up. Oh, what's that? I have hypertension upstairs, but hypotension downstairs, and this is called pressure difference. And this is a very important feature of aortic coarctation. Next, let's feel the brachial pulse upstairs, and let's feel the femoral pulse downstairs. Which one is gonna happen sooner? Of course upstairs, because we have more blood and more pressure. So we will bring more blood to the upper part of the body faster, and less blood to the lower part of the body, and it's gonna take longer. What do you call this? This is a phenomenon known as brachio-femoral delay. Another key feature of coarctation of the aorta. So for coarctation of the aorta, remember pressure difference and brachio-femoral delay. Do not call this pulsus difference, because pulsus difference is a difference between the right pulse and the left pulse, not between the upper pulse and the lower pulse. Big difference. This phenomenon is brachio-femoral delay, not pulsus difference. Okay, now I have a problem. There is more blood going upstairs and less blood going downstairs. Oh, the lower half of the body will suffer. Okay, now therefore let's open anastomoses. Let's open collaterals that are normally not open to communicate between this wide area of the aorta and this narrow area of the aorta. How do you do this? Well, this upper part of the aorta will give me the subclavian artery, right and left. The subclavian artery will give me internal thoracic artery or internal mammary artery, which will give me many anterior intercostal arteries. The anterior intercostal arteries, for the first time in history, will anastomose and make collateral circulation with the posterior intercostal vessels. The posterior intercostal arteries come from whom? They come from your descending thoracic aorta. Oh, that's awesome. So oxygenated blood from the aorta before the obstruction went to that collateral circulation and supplied oxygenated blood to the aorta distal to the obstruction. That's the beauty of the collateral circulation. Where's that collateral circulation happens? Intercostal vessels. Oh, intercostal between my ribs. Yes, so if you feel your patient's chest on the right and left hemithorax, what will you feel? I'll feel palpable, abnormal arterial pulsations on the thorax. Why? Because of the fact that the collaterals in the intercostal area are open for the first time. If you do x-ray, what's going to happen? You'll find rib notching, because remember that the vessels are near the rib. Here is my rib, amazing, and near it what do I have? I have intercostal arteries, intercostal veins, and intercostal nerve. Can you tell me which one is up, which one is in the middle, and which one's down? Drop your answer in the comments. The moral of the story is the intercostal arteries are near the ribs. When they enlarge because of the fast collateral circulation, they will keep notching the ribs, notching the ribs, notching the ribs, giving me rib de la noche, I mean notching of the ribs. I am not multilingual at all. Okay, we have tons of pressure before the obstruction. High pressure, high pressure. Who has to pump blood against this very high pressure? The answer is the left ventricle. Oops! Left ventricular pressure overload, which will eventually lead to left ventricular hypertrophy, which can eventually cause left-sided heart failure, which can lead to what? It can lead to blood piling up and pooling in your left atrium, and then it's gonna pile up and pool inside your lungs, giving you pulmonary congestion. You will cough pink, frothy sputum. Why pink? Because of blood. Why frothy? Because of air in the lungs. You get wet pulmonary crackles, you may get hemoptysis and repeated chest infections. And if that was not enough, the high pressure here, proximal to the obstruction or to the narrowing, can lead to what? Oh, it can lead to an aortic aneurysm, or aortic dissection, which can rupture, leading to internal bleeding, maybe sudden death. And if that was not enough, the very high pressure upstairs is gonna give me headache, visual problems, aneurysm in my brain, which can rupture, causing subarachnoid hemorrhage, the worst headache of my life. Thunderbolt headaches. Fortunately, most patients, especially if you are an adult already, have very mild disease, sometimes even asymptomatic. They have no idea that they even have coarctation. However, some cases are very severe and they will present in neonates. Why is this? Let's go back to embryology. Remember this junction or the connection between the pulmonary artery and the aorta. It was called what? It was called ductus arteriosus. And because during embryological development, the pressure in the pulmonary artery is higher than the pressure in the aorta because the lung is a dark place with very high resistance, blood will flow from the pulmonary artery to the aorta. Amazing. And then what? Well, this is all nice and cool. Why is this cool? Because this blood is replacing the low blood flow downstairs. But hey, medicoses, this blood is deoxygenated, right? You're giving deoxygenated blood to the oxygenated blood. Yes, indeed, but it's better than nothing because remember, what is your PVO2? Oh, it's about 40 millimeters of mercury. And what is your arterial oxygen? Oh, it's about 100. So the deoxygenated blood does not mean zero oxygen. It means we have less oxygen than the artery, which is better than nothing. It's better for your feet to receive some blood than no blood, even if that blood is relatively less oxygenated. Oh, so this ductus arteriosus is important in cases of aortic coarctation. That is especially correct. However, once I'm born and I take the first breath, what's going to happen? This ductus arteriosus will get obliterated and become ligamentum arteriosum. Therefore what? No blood will reach the lower part of the aorta. Oops, and what's going to happen? This neonate can suffer from cardiogenic shock because of inadequate tissue perfusion, and sometimes cardiac failure, heart failure, which can manifest in many symptoms, but don't forget diaphoresis and poor feeding. And that's a tricky question in pediatrics because when most students read diaphoresis and poor feeding, they never think of heart disease. So aortic coarctation could be congenital most of the time or could be acquired. Aortic coarctation also could be preductal or postductal. Preductal means what? The coarctation started, the beginning was before the ductus arteriosus. Postductal means what? The coarctation started after the ductus arteriosus. But whether it's preductal or postductal, make no mistake about it, it's almost always distal to the left subclavian. Here's the left subclavian, here's the left subclavian, and the coarctation started distal to the left subclavian, here and here. Why is severe preductal aortic coarctation so bad in neonates? Because they were dependent on the ductus arteriosus to supply the lower half of the body with some blood. But once this closed, after the closure, what's going to happen? I can get cardiogenic shock and cardiac failure, which can lead to diaphoresis and poor feeding. This is only true for neonates who have severe preductal coarctation. But what if I'm an adult already? I'm 40 years old. Then even if you have coarctation, it's very mild and it's postductal. That's why no one noticed any change when your ductus arteriosus closed. But the infantile or the pediatric form is prior to the ductus. It is preductal, which means before the patent ductus arteriosus. What are the important signs of aortic coarctation? Number 1, pressure difference. Number 2, brachio-femoral delay. One is describing blood pressure and one is describing the pulse. Third, you can feel abnormal pulsations on the right and left hemithorax because of the collateral intercostal circulation that opens up. You can assess the brachio-femoral delay with your hands, just feel the pulse, or with ultrasound, the famous ankle brachial index. Coarctation of the aorta could be associated with other diseases, such as other cardiac defects, including bicuspid aortic valve. Now, if bicuspid aortic valve caused a murmur, how will that murmur sound like? Drop your answer in the comments. It can also be associated with patent ductus arteriosus or ventricular septal defect. Aortic coarctation could be associated with syndromes, most famously Turner syndrome, then you have Sturge-Weber syndrome and Williams-Buren syndrome. If you're studying for the boards, the two that they ask about the most are Turner syndrome and bicuspid aortic valve. Aortic coarctation could be preductal or postductal, infantile type or adult type. Aortic coarctation could be congenital or acquired. Is this congenital one, which means I'm born with it, caused by a genetic mutation? Well, so far we have never found a genetic mutation associated with aortic coarctation. Yes, it tends to run in families for some reason, but we have not pinpointed the gene mutation yet. So when it's not gene mutation, what do you call it? I call it mostly sporadic. It arises on its own. So far, we have not found a bad gene that runs in families. But don't forget, we also have acquired aortic coarctation. which means I was born with a beautiful aorta up and down. But later, I acquired a coarctation later in life. How come? Maybe you have Takayasu arthritis. Oh, this one affects the aortic arch big time, and the branches of the aortic arch big time. Or how about severe atherosclerosis? Atherosclerosis is part of arteriosclerosis, and here's an artery. Oh, hardening of the artery can lead to coarctation if it is severe enough. Anyways, aortic coarctation will lead to outflow obstruction, okay? Which leads to what? It raises the blood pressure upstairs and it lowers the blood pressure downstairs, and this is called pressure difference. It makes the brachial pulse take place before the femoral pulse, upstairs versus downstairs, brachio-femoral delay. In order not to make the matters worse, we open collateral circulations, intercostal arteries, between the anterior intercostal arteries and the posterior intercostal arteries. And this will lead to what? Rip de la noche and feeling the abnormal pulsation over the patient's chest. Why did the collaterals open in the first place? To supply more blood to the lower part of the body. Aortic coarctation outflow obstruction, which leads to what? It's a load on your left ventricle because it has to pump blood against this high resistance, which means the left ventricle will experience pressure overload, S4 heart sound, left ventricular hypertrophy, concentric, not eccentric one, and eventually it leads to left-sided heart failure. Let me tell you why most doctors are atrocious. They forget to measure the blood pressure upstairs and downstairs. They only measure one of them. And therefore, there is no way you can assess pressure difference. Whenever your patient complains of headache and blurry vision upstairs, claudications and blue legs downstairs, you should measure the blood pressure upstairs and downstairs to assess for pressure difference. The collateral circulation is an important board question, especially for Step 1 USMLE and COMLEX. They ask you where are the collaterals between what and what. Here's the story. Look, here is the aorta, right? What is the purpose of the collateral? I want to open a junction. I open a passage between pre-obstruction and post-obstruction, which means between the aortic arch and the descending thoracic aorta. So let's do it. The aortic arch will give me subclavian arteries on the right and on the left. And this will give me what? Internal thoracic arteries. It descends downwards like this. It will give me many of the anterior intercostal arteries, which will anastomose for the first time with the posterior intercostal arteries. You open a collateral here, blood flows from this side to this side. Now the blood, which is oxygenated, is going to go to the posterior intercostal arteries and it will flow back to the aorta, which sounds weird because normally in the arteries the blood goes this way, from the aorta and towards something else. But in this case, it is going towards the descending aorta in order to supply blood to the lower extremities. This sequence is very important to remember for your exam. Let's summarize what we've said today. What's aortic coarctation? It's narrowing of the aorta, thickening of the tunica media of the aortic arch, probably due to abnormal development of the aortic arch during embryology. Many patients are asymptomatic, many patients have mild symptoms, but severe aortic coarctation in neonates can lead to the following when the ductus closes: heart failure and cardiogenic shock with sweating and poor feeding, hypertension upstairs, headache and epistaxis, hypotension downstairs, cold legs and claudications. On physical exam, pressure difference, brachio-femoral delay. The pressure has a problem and the pulse has a problem. This brachio-femoral delay is not the same as pulsus difference. Hypertension upstairs can lead to bari or saccular aneurysm, which can rupture, leading to subarachnoid hemorrhage. The pulse in the patient's upper arm is very strong and the upper arm is warm, but the lower legs are what? Cold to the touch. Downstairs, blood pressure is low, the lower limbs are cold with weak pulses. And anytime you have hypotension, what's going to happen? Renin, angiotensin-aldosterone system, will release tons of renin from your kidney and tons of angiotensin II and then tons of aldosterone, which can lead to secondary hypertension. Moreover, you can feel the pulsations of the intercostal arteries because of the collateral circulation, the same collateral circulation that causes rib notching. Complications of aortic coarctation include outflow obstruction, which puts a pressure and a load on the left ventricle. It causes hypertrophy of the left ventricle. Notice I said left ventricular hypertrophy and not left ventricular hyperplasia, because the cardiac myocytes are permanent cells. They do not divide, even if you drink all your milk. When the cardiac muscles get injured, they can get bigger. but not more numerous. So if 10 years later I'm in a car accident and I became your patient and I've heard you utter the word left ventricular hyperplasia, I'm leaving. I'd rather succumb to my contaminated open wounds than be treated with a doctor that says left ventricular hyperplasia. Next, hypertension upstairs, aneurysm in the brain, and cystic medial degeneration of the aorta, which can lead to aortic dissection, aortic aneurysm, and even rupture. Anytime there are problems close to the heart, just like this, which overwhelm the left ventricle, can lead to what? Stagnation of blood and infective endocarditis. Anytime you have stagnation, you're calling for bacteria. How can we diagnose aortic coarctation? Listen to the patient's history, physical exam, look at the three things: pressure difference, brachio-femoral delay, and palpable pulsations of the intercostal arteries. That's the clinical diagnosis. Next, chest x-ray to see what? The rib notching because of the collateral intercostal vessels. And 3 sign on x-ray. What's that 3 sign? I want you to look carefully how 3 looks like. Oh, look at this. Look at this. That's exactly how the aorta looks like when we have aortic coarctation. Look at this. This is the 3 sign, and you can see it while looking at the aorta on chest x-ray. Echo can help us, and catheterization. We're basically measuring the pressure difference from between before the obstruction and after the obstruction. There is a difference. Is it significant or not? That's the question. Treatment. If it's very mild and the patient is asymptomatic, no treatment necessary. But infants with severe disease, do everything you can to prevent this ductus arteriosus from closing, such as giving prostaglandin E, which keeps the PDA open. Keep that ductus arteriosus open. How about cardiogenic shock that can happen in severe diseases? Give dopamine. And for these severe cases, of course, we need surgical repair. But what if it's moderate? Well, if it's moderate, it's usually secondary hypertension, right? Oh yeah, the patient has high blood pressure. You can give beta blockers and you can manage this as if it's just hypertension. If it is that bad, then it's time to repair it. You can do that surgically. Sometimes the open A bypass between proximal to the obstruction and distal to the obstruction, so they connect these two ducts together, just like this, to provide more blood downstairs. Or you can do it percutaneously without opening the patient's chest. How come? A balloon with stent. Oh, to keep this part open to ensure adequate flow to the stuff in the lower half of the body. Note that if you're talking about a pediatric patient who weighs less than 25 kilograms, i.e. very small, do not put a stent for the most part. Why not? Because you will need to replace the stent many times as this child grows older and older and older, because the aorta keeps getting older and bigger, but your stent stays the same in size, which means you have to change it. So every few years I gotta remove the stent and put another stent, remove the stent and put another stent, which is a pain in the neck, in the thorax. Associations of aortic coarctation, we have other cardiac defects and other syndromes. Don't forget Turner syndrome and bicuspid aortic valve. Aortic coarctation has a weird synonym, which is congenital hypoplasia of the aortic arch. Quiz time. Please describe the murmur that you'll hear if a patient has bicuspid aortic valve, if it is severe enough to cause a murmur. What will that murmur sound like? Let me know your answer in the comments. If you want to learn about angina, myocardial infarction, and many types of cardiac arrhythmias, please download my emergency medicine high yields course at medicosisperfectionalis.com. To learn about vascular surgery and cardiothoracic surgery high yield topics, download my surgery high yields course at medicosisperfectionalis.com. To learn about pharmaceutical options for the heart, such as antihyperlipidemics, antiarrhythmics, antianginal, antihypertensive, diuretics, and digoxin, download my cardiac pharmacology course at medicosisperfectionalis.com. Each one of these 3 courses comes with videos, questions, answers, and my notes, of course. There are more than 1,500 free videos on this channel, plus 300 plus videos only to those who click the join button and choose the highest tier. Smash like, subscribe, hit the bell. Please support the channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you'd like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.